In the previous classes, we've talked about the various types of lower extremity wounds, and we've talked about the importance of accurately determining the etiology in order to determine appropriate management. So in this session, we're going to talk about guidelines for accurate differential assessment and management of lower extremity wounds. And we're going to be focusing primarily on the big three: venous, arterial, and neuropathic. Now, we've talked about why it's so important to get the diagnosis right, to know what type of wound you're dealing with. Obviously, if it's a venous ulcer, you're going to have to provide compression therapy in order to improve venous return and get that ulcer to heal. But if the patient has some coexisting arterial disease, you will need to modify the level of compression to improve venous return while avoiding any compromise in arterial inflow. If the wound is arterial in etiology, your whole focus is getting that patient in to see vascular, making sure that they maintain hydration, looking at smoking cessation, all designed to improve perfusion. And of course, if the wound is neuropathic, our big focus is offloading the ulcer, making sure the patient is not walking on that plantar surface ulcer. If we get it wrong, if we assume that it's a venous ulcer and we fail to look at our vascular parameters and we fail to recognize that that patient has a compromised ABI, then we're going to apply full level compression and we're going to worsen that patient's arterial perfusion, meaning that we might make the venous ulcer better, but we might create significant arterial compromise. If we fail to recognize that it's a venous ulcer and we don't provide compression and elevation, the wound won't improve. If we look simply at the fact that the patient's diabetic and we don't differentiate between an arterial wound and a neuropathic wound, again, our management is going to be incorrect and the wound will not heal. So to do differential assessment, you have to go back and make sure that you have all of the critical data. I was talking to someone last week and we were talking about the fact that in many wound centers, what happens is people walk in, they look at the wound, they're like, oh, it's around the medial malleolus, it's venous. They don't check pulses, they don't check an ABI. Even if they're correct in identifying the ulcer as being venous in terms of etiology, they don't know what level of compression can be safely applied. And they may miss the diagnosis altogether if they fail to gather the critical information, the critical data. So your essential baseline data must include a vascular assessment. You want to look at the color of the leg and the foot, and you want to see what happens when you put the leg up and down. Is there elevational pallor or cyanosis? Is there dependent rubor? You want to look quickly at the skin, hair, and nails. Do you have that thin, shiny skin? Do you have diminished or absent hair growth, and is this a change? Do you have thin, ridged nails? All of those are indicators for arterial disease. If the skin looks pretty normal, if you have hair growth, if you have normal nails, then you're much less likely to have any significant arterial disease. You're always going to check pulses. That's why that is in bold. You have to check pulses on all of your patients. And you're looking to see, are pulses normal? Are they diminished? Are they non-palpable? Cap refill, venous refill, helpful. Not as critical as some of the other data. ABI critical. You never want to apply compression therapy without doing an ABI. ABI is going to help you to accurately identify wounds that are caused by arterial insufficiency. They're also going to help you identify patients who need modified compression for management of venous ulcers. And of course, your alert to edema, which is a major indicator for venous disease. You also need your sensory motor data. This is particularly critical If you have a patient who is a known diabetic, if you have a patient with any history of B12 deficiency, if you have a patient who cannot tell you when or how this ulcer began. In those patients, you absolutely must gather your sensory motor data. And of course, the most important is checking with monofilaments, the 5.07 monofilament to determine loss of protective sensation. You also want to check for position sense to see if the patient knows where their feet are in relation to space. You want to look for any deformities that would be indicative of motor neuropathy. You want to be very alert to callus formation because that's a pre-ulcerative lesion. Now, when you think about differential assessment, the parameters that are most helpful to you are going to be the pain pattern, that's critical, the location, the condition of the wound bed, and volume of exudate. And then you always compare that pattern to your vascular and sensory motor data to be sure that it's a match. So let's go over what we already know. Venous ulcers, where are they located? Between the ankle and the knee, typically around the malleoli. They're usually red and wet because there's a lot of vascular congestion in the area of the ulcer. And their pain pattern is aching pain that's relieved by elevation. So it's typically worse at the end of the day, better in the morning, relieved by elevation. Edema is common in patients with venous ulcers, so is that hemosiderosis. Typically, you would expect when you go to your vascular data to find a patient with basically warm feet, palpable pulses, and an ABI greater than 0.5. In contrast, if your wound is arterial in etiology, where is it going to be located? Distally, farthest points from the heart, so the toes, the distal foot, or in areas of trauma that have failed to heal because there's not enough perfusion to support healing. The ABI is typically less, well, I shouldn't say typically, the ABI will be less than 0.5. If your ABI is greater than 0.5, it tells you that you have enough blood flow to heal a wound and you would not get a spontaneous ulcer. So if your wound is arterial in etiology, your ABI will be less than 0.5 or greater than 1.3, meaning the vessels are totally incompressible. What will your wound look like? It'll be pale, dry, possibly necrotic, because there's very little blood flow to the wound bed. And what's your pain pattern going to be? Pain will be worsened with elevation because now blood has to go uphill. It will be worsened with activity because that increases oxygen demands. The pain will be relieved by dependency and by rest. If your wound is neuropathic, the wound is going to be located on the plantar surface or on areas of the foot in contact with the shoe. So it's either going to be on the plantar surface, the tips of the toes, the periphery of the foot, or the tops of the toes where they're rubbing against the shoes. Very different than location for a venous ulcer. Very different than location for an arterial ulcer. Typically, you'll have a red ulcer bed. They may not complain of any pain at all. Typically, they don't complain of any pain at all unless there's something else going on like coexisting arterial disease. However, they may complain of neuropathic pain, which is that pins and needles, electric shock kind of pain that is typically relieved by walking it off. Okay, so let's put this all together. And I think the best way to do it is to do a practice scenario. So that's what we're going to do. You have a 67-year-old black female referred to your wound clinic for a non-healing ulcer on the left leg. That tells you nothing. Relevant medical history. She has type 2 diabetes. She's had it for 20 years. She's managed with glucotrol XL and diet. Her last A1C was 7.2, so she's fairly well controlled. Could be better. Hypertension managed with low tensin. No history of MI or CVA, a questionable DVT following cholecystectomy 2 years ago. Social history, she lives alone, she's cognitively intact, She has no tobacco or alcohol use. Now let's look at our critical data. It's going to be our vascular data. It's going to be our sensory motor data. It's going to be our pain pattern and our ulcer characteristics. So on vascular assessment, no elevational pallor or dependent rubor. Pulses are palpable but somewhat diminished. ABI on the right is 0.84. ABI on the left is 0.76. She has 2+ edema in the left leg. Her capillary refill is 3 seconds bilaterally. Now, if you just stood back and you looked at all of that data together, your assessment would be, well, she has some evidence for venous disease because she has 2+ edema in the left leg. When you look at her ABI, her pulses, the other vascular indices, you would conclude that she has moderate lower extremity arterial disease, not severe, mild to moderate. 0.84, mild, 0.76, moving into the moderate range. Would you ever develop an arterial ulcer with an ABI of 0.84 and 0.76? No, so I'm already thinking it's not arterial. But we'll come back to that. Sensory motor assessment, no response to 5.07 monofilament bilaterally. She does respond to the 6.10, so that means she has loss of protective sensation, but she's not totally insensate. She has hammer toes, second through fourth toes bilaterally, so she does have motor neuropathy as well as sensory neuropathy. She has a marked callus over the first metatarsal heads bilaterally, a pre-ulcerative lesion on both plantar surfaces, and she has dry feet. So she has sensory neuropathy, motor neuropathy, and autonomic neuropathy. Now let's look at our specific data that's going to tell us what kind of ulcer we're dealing with. Let's look first at the pain pattern, which is very, very significant. You pay a lot of attention to pain pattern. It's minimal in the morning. It's worse at the end of the day. Described as aching, relieved by elevation and ibuprofen. She also has occasional burning pain in her legs at night that's relieved by walking. So that aching pain that's relieved by elevation and ibuprofen, that's clearly venous pattern pain. And that burning pain that's worse at night and relieved by walking matches neuropathic pain. Your ulcer assessment is located at the medial malleolus on the left leg, so that's consistent. That location is consistent with venous. Pain pattern is consistent with venous. Measures 8.5 by 6.6 by 0.0, so it's superficial. That matches venous. The ulcer bed's 80% red and 20% yellow film, consistent with venous. Large amounts of clear yellow exudate, causing maceration of the surrounding skin. So all of those parameters match venous. So if you put it all together, she has risk factors for arterial, venous, and neuropathic. But remember, risk factors just tells you that, yes, the patient has medical history that would be consistent with development of this type of ulcer. It does not tell you what you have. The ulcer location, the ulcer characteristics, the volume of exudate, and the pain pattern are all consistent with venous. If you go back and you look at your vascular data, you can rule out arterial as the etiology. If you look at location, you can rule out neuropathic as etiology. Okay, so this is a venous ulcer. Now we go back and we say, well, how are we going to manage it? Well, standard management is compression and elevation, possibly surgical intervention. But I've got to review my vascular assessment data to see if there's any contraindications to standard therapy, if I need to modify my standard therapy. She has ABI less than 0.8, so we'll need to do modified or light compression. What about topical therapy? Well, we're going to protect the peri-wound skin because it's macerated. We're going right back through our usual list, okay? We're going to use an absorptive antimicrobial dressing because it's a wet wound and she has that 20% yellow film. that is consistent with critical colonization and biofilm formation. So we're going to protect the macerated skin. We're going to use an absorptive dressing that has an antimicrobial agent to address the critical colonization. And we're going to do light compression. We're either going to do a 4-layer, modified 4-layer wrap, modified 2-layer, modified 3-layer. We're not going to use full compression. When we go back and we review sensory and motor data, we find that she definitely has neuropathy, so she needs intensive education. She has hammer toes. We need to make sure that her footwear is being professionally fit so that she gets shoes with a deep toe box. She has pre-ulcerative lesions on the metatarsal head, so she needs appropriate insoles. She cannot buy her shoes off the rack. She has to be professionally fit. She needs intensive education about foot care and monitoring. So she needs to know, shake out your shoes, never ever go barefoot. Check your feet at the end of the day. Moisturize your dry skin, dry well between the toes, all of those things. She needs to understand the importance of tight glucose control so that we minimize the risk of further progression of her neuropathy, okay? And careful daily inspection. So to summarize, to do accurate differential assessment, start with the data you must collect. You must do a basic vascular assessment. Look at your skin, hair, and nails. Check for elevational pallor or cyanosis and dependent rubor. Check your pulses. Ideally, check venous filling time. Check your ABI. Check for edema. If you have a diabetic patient, a patient with B12 deficiency, a patient with any clinical indications of neuropathy, you must check with your monofilaments. You're always looking for deformities to rule out motor neuropathy. You're checking for very dry skin or very wet skin to rule out autonomic neuropathy. Then you gather data about your ulcer and about pain. Once you have all of your data together, the factors that point you toward wound etiology are going to be your pain pattern, the location of the ulcer, the color of the wound bed and volume of exudate, and the surrounding tissue. Once you've identified primary etiology, go back to your vascular data and sensory motor data, but most especially back to your vascular data to determine, can you do standard management? Do you need to do modified management like compression instead of full compression? Does your vascular data match your determination of causative factor? For example, if you got confused and you were thinking this was an arterial wound and you went back and you had 2+ pulses, ABI 0.84, no elevational pallor or cyanosis, no dependent rubor, you'd have to go back and re-evaluate the cause of the wound, because you would never ever develop an arterial ulcer without having marked reduction in ABI, very clear elevational pallor or cyanosis and dependent rubor, prolonged venous filling time, absence of hair, all of those things. So look at pain pattern, location, status of the wound bed, volume of exudate to form your initial impression. Check your initial impression against your vascular data. That will help you verify that you're on track with your initial impression. And it will also give you the additional information you need to know whether or not you can proceed with standard management or you need to modify it. We'll go over this again when you're on site, but I want you to have this in the back of your mind as you're studying, because that's the goal. We want you to understand arterial disease, venous disease, neuropathic disease. We want you to understand how those ulcers present. We want you to know how to do differential assessment and appropriate management. Thank you.